Bom, boa noite a todos. Eu declaro aberta a 15ª sessão ordinária relativa ao 196º ano acadêmico. Inicialmente, nós devemos aprovar, ou não, a ata da 10ª sessão ordinária do dia 29 de maio de 2025. Alguma observação? A seguir, estamos abertos para as comunicações dos acadêmicos. Se não tiver, eu tenho algumas comunicações interessantes. A primeira é o lançamento do livro do nosso confrade Gerson Lima da Silva, Poema de Papel, que será no dia 23 de julho deste ano, obviamente. É uma quarta-feira, às 19 horas, na Livraria da Travessa, no Shopping Leblon. Eu acho que Gerson ficará extremamente feliz se o número grande de acadêmicos forem prestigiá-lo, como eu irei, por exemplo. A outra coisa que eu gostaria de falar é que nós temos um correspondente da Fiocruz, Luiz Augusto Galvão, que mora nos Estados Unidos e todos nós conhecemos como Guto Galvão, e ele foi o responsável por me apresentar o presidente da Academia Americana de Medicina, o professor Vitor Zau. E agora nós pensamos inicialmente em fazer um programa conjunto com a Academia Americana de Medicina, mas não vamos fazer porque já temos uma viagem para Portugal e uma viagem para Paris em setembro e outubro, mas provavelmente nós faremos uma sessão online junto com a Academia Americana de Medicina, que virá aqui para a COP30. E ele está muito interessado que nós juntemos forças para discutir junto com a Academia Nacional de Medicina dos Estados Unidos a respeito do problema clima e saúde. Eu acho que é uma coisa que interessa a todos nós, e acho que, independente dos presidentes das respectivas nações virem ou não virem, eu acho que é um problema médico que nós precisamos estar presentes. Então, eu vou fazer essa convocação também na próxima quinta-feira, porque eu gostaria muito que nós tivéssemos muitos acadêmicos presentes por ocasião da possibilidade de uma interação maior com a Academia Americana de Medicina. Eu vou propor isso também à Academia Francesa de Medicina. Muito obrigada. Eu gostaria também de anotar que hoje, não sei se ele pode ainda receber parabéns, mas hoje é o aniversário do acadêmico Roberto Soares de Moura. E nós gostaríamos de lhe enviar os parabéns. Eu vou telefonar para a filha dele, a doutora Ana Tereza, falando que nós comentamos aqui e que vamos dar os parabéns para ele. Eu gostaria de chamar à mesa, depois disso, para continuarmos o simpósio, o acadêmico Rossano Fiorelli, o professor Gustavo Fraga, da UNICAMP, e quem mais? E o professor Pedro Cortari, presidente do CBC, por favor. E vou passar os trabalhos e a organização ao acadêmico Rossano Fiorelli, que foi um dos organizadores desse simpósio.
Bom, dando continuidade, então, ao nosso simpósio de trauma, nós vamos fazer uma pequena inversão da pauta. O professor Caio Lewandowski, nosso correspondente estrangeiro da Academia Nacional de Medicina, radicado em Tucson, vai proferir inicialmente a conferência dele de modo virtual. Então, professor Caio, muito obrigado por estar presente virtualmente, e sua conferência vai ser Cirurgia Traumatológica e Ortopédica, Experiência nos Estados Unidos. O professor Caio é professor da Universidade do Arizona, e chefe de uma clínica ortopédica e cirurgia minimamente invasiva em Tucson.
Muito bom dia. Vocês podem ouvir?
Sim.
Perfeitamente.
E tem vídeo? Você pode ver a apresentação?
Sim.
Ok. Muito obrigado. Hoje vou falar em inglês, por favor. Não tive muito tempo para preparar a palestra, ok? Tá bom?
Ok. Sim.
Okay. My assignment was to talk about the traumatology system in the United States from an orthopedic perspective and how the system works and what the impact is on musculoskeletal trauma care. 60% of all trauma in the United States is orthopedic and accounts for fractures. And what I'm presenting today is based on the Orthopedic Trauma Association guideline, and I will walk through the system, how it's set up. We have 4 trauma center levels, and the accreditation is based on what level of service they provide. The verification is done by the American College of Surgeons and ensures that trauma centers meet specific standards for patient care and safety, and the verification process is crucial for maintaining quality and, most importantly, payment. The Trauma Quality Improvement Program is an initiative, the TQIP, that is essential for trauma centers to meet benchmarks on their performance, and they're measured by these kinds of standards. There is a mandatory orthopedic coverage if a center wants to have the accreditation for level 1 or level 2, similar to neurosurgery. Level 3 centers may get away without that. However, level 1 and 2 need orthopedic coverage. There's a strong emphasis on using metrics and performance improvement drive the effectiveness of the trauma system in the United States by focusing on data collection, analysis, and implementation of best practices. And we all have to deal with that in the documentation requirements through the electronic healthcare system. Initially, there's triage and transfer protocols, and that's important in assessing unstable patients. For example, pelvic fractures, where do they need to go? Open fractures are common injuries that are referred to level 1 and level 2 trauma centers, and they need to be treated there. If they arrive at lower trauma centers, there's mechanism for transfers. Spine injuries are typically at a lower level of urgency, particularly with spinal compression fractures. Spinal cord injuries are a whole other story, and they need to be at level 1 and level 2 centers, mostly for stabilization. Injuries to the extremities with vascular injuries are also something that needs to be in a level 1 and level 2 trauma center, mostly to prevent limb loss. They have the ability of a multi-team approach for limb reconstructions, blood transfusions, etc. Standard transfer protocols exist, and I will talk about those later in the presentation. There's an orthopedic worksheet or transfer sheet that every trauma center has that determines the custody of the patient, the chain of command, so to speak. Antibiotic administration is very important, particularly in open fractures. We have a classification, the Gustavo classification, that says type 1 and type 2 fractures need to be managed with antibiotics within 60 minutes, mostly cephalosporin. And here's the classification, and you can see that grade 3 injuries are by far worse and have complicated lymph salvage surgery involved, and the infection risk is much higher, which is basis of the classification and requires different treatments, which again is mostly done in level 1 trauma centers. Surgical management and prophylaxis, the intervention is also very vital for open fracture. Debridement should be performed within 24 hours to remove the vitalized tissue. The standards for open fractures have changed a little bit. When I started training 20 years ago, every open fracture, regardless of size, went to the OR within 1 hour. The standards have changed. And now within 24 hours for grade 1, grade 2, and these other more severe injuries, grade 3 fractures need to be treated on a more protracted acute basis. Damage control, indicated mostly for polytrauma patients. So the orthopedic role in that situation is to stabilize extremities and pelvic fractures, often temporarily until the patient is stabilized from a vascular perspective. Initial management may include external fixation or traction devices, and the performance is then monitored through improvement protocols to make sure that the follow-up care, the definitive care, is actually done within a timely manner as well, and it's recommended that the definitive treatment occurs within 48 hours from admission. Comprehensive management of mangled extremities is a whole nother complex subject. The controversy here is whether to amputate or to salvage. And obviously the emphasis in our world, in the United States, is to salvage extremities, and that involves a multi-team approach, and it needs the availability of vascular surgeons, neurosurgeons, and orthopedic surgeons, as well as plastic surgeons. And those kinds of service can only be delivered in level 1 trauma center for the most part. Compartment syndrome is also a common problem that leads to medical legal scenarios if not recognized. And the key symptoms are disproportionate pain, and it's very time sensitive, and the patient needs to be treated in an expeditious manner. Besides pain, paresthesias, numbness and tingling to passive stretch, for example, or increasing swelling in the extremity is also of relevance. And if there's any suspicion of compartment syndrome, the intracompartmental pressure, I'm talking mostly about your lower extremities, should be measured with a measuring device. It's easy, can be done on a bedside. Any pressures exceeding 30 millimeters of mercury need to be debrided, which is shown here in the next image. And there's various school of thoughts on how to do that, single incision, dual incision, beyond the purview of this presentation, but there's various ways of doing it. The key element, though, is that patient does get the fasciotomy if there's elevated pressure to save the extremity. Now, pelvic fractures are often unstable in polytrauma patients, and their management is obviously very resource intensive. That needs to play out in level 1 trauma center, where a pelvic girdle can be immediately applied, and then the patient can be either treated with provisional external fixation and then definitive treatment within 48 hours, ideally. DVT management is of relevance there, embolization of ongoing bleeding. If patient is not going to the OR, these are very sick patients that have a mortality rate of about 30% if not treated effectively within the first 48 hours. Key factors in geriatric hip fractures, I want to touch on that briefly. These come in usually to level 3 and level 2 trauma centers. We're talking about femoral neck fractures or hip fractures. And again, the modern standard calls for fixation within 48 hours. And the plan of care could consist either of arthroplasty, meaning total joint replacement, or open reduction or internal fixation. The trend now is to do more arthroplasty in a selective setting. And here are the criteria listed. What type of fracture, based on what functional demand the patient has, is ideally suited for an arthroplasty. A lot of open reduction and internal fixations for femoral neck fractures, for example, go on to develop post-traumatic hip arthritis. And then we found in our country that treating them with a primary arthroplasty actually is a better utilization of resources and leads to lower complication and reoperation rates. Importance of multi-center care or multidisciplinary care is very important. On the backbone of surgery, there has to be a rehabilitation team. There has to be a team of geriatricians that can handle the social aspect of where the patient goes after hospitalization, which facility, a step-down facility, a skilled nursing facility, or a rehab facility based on what the patient is able to do and what their values and expectations are. The key element to all of that is to do early rehabilitation to avoid complications such as deep venous thrombosis, which is then associated with pulmonary embolus and other life-threatening complications. I want to touch very briefly on supracondylar pediatric fractures. That is something that comes through level 3 and level 2 trauma centers, emergency rooms, quite a bit, particularly when kids are out playing in the summer. And these types of fractures are somewhat emergent and need to be treated surgically, particularly when there's a Galeazzi type or Gerhardt classification type 2 and 3 fractures with dislocation or with substantial displacement. Services need to be available for that because in this age group, deformity with completion of growth is common, and efficient early treatment is key to preserve function. The key components of our rehabilitation system in a multi-system trauma setup are as follows. There's early rehabilitation that plays out usually in the hospital, sometimes even if there's stable fractures leading up to the operation to mobilize patients better, mostly post-operatively. And then a multidisciplinary team approach is chosen post-operatively. Where does the patient go? Again, functional demand, age appropriate. Do they need emotional, social support? There's services for that in the social service department. There's a nutritional department. There's quite a variety of folks that are involved in that. ICU rehabilitation, if the patient is in the ICU, we call for physical therapists to come to the ICU unit for passive range of motion exercises, even if the patient is unconscious and intubated or sedated. These occupational therapists also work on the upper extremities. Physical therapists and bracing therapists work on protecting the feet, ankle, and elbows for decubitus and skin breakdown. So these are all additional elements that routinely play out. Communication is key, and a well-structured and well-run trauma center has daily, early in the morning meetings to coordinate care, what came in last night, and who needs to go where, and where do the resources get assigned. Essential indicators of trauma outcomes, timely administration of antibiotics. That's one of the key measures in the Trauma Performance Improvement Project. Timely debridement and efficient transfer of care to another center if the care cannot be provided at the local trauma center. And we have a law for that and a system that tracks that. It's called the EMTALA law that regulates transfers between hospitals and emergency rooms. And Medicare mandates in the United States that every hospital has to take a patient on regardless of insurance status, whether they can pay or not, and treat them. However, if that hospital determines they don't have the level of service available, for example, if a level 3 trauma center or 2 does not have an orthopedic surgeon on call or available when needed, then the transfer to another facility needs to be arranged, and that facility has to take the patient. Otherwise, there'll be legal consequences and financial consequences to the hospital. Documentation and benchmarking obviously is key to that. I mentioned the Trauma Quality Improvement Program earlier, and these benchmarks are routinely tracked for recertification and transfer problems that I alluded to earlier. They do get reviewed, and penalties are filed if the system fails the patient that comes in for acute trauma care. Future directions and challenges. Obviously, post-COVID, we have a lot of influx and outflux of staff, a lot of problems with training and retaining people. Nursing staff have rotated quite a bit. We have traveling nursing services that overcharge, and the system is now slowly bouncing back to a bit more normality in that. However, we routinely find today still that you go to the hospital and you work with people you never met. So working in teams is key to improve outcomes and to meet the benchmark requirements. And it remains a challenge for us in the current environment. Hopefully, AI and robotics can at least help us with some system integration, particularly in making information from other facilities available quickly, so patients can be managed effectively and transferred effectively to manage the workflow so that lives are saved and complications are diminished. International collaborations, of course, the purpose of today's talk is to put out what we're doing here in the United States versus in Brazil, and hopefully there's a little bit of time in the question and answer session to point out some differences that may or may not exist in how the healthcare system is prepared to deal with them. The key element to U.S. trauma care model is quite simple. It's built on the foundational principle of early intervention, effective coordination among care teams, and strict adherence to established guidelines. I thank you very much for the opportunity to present some of the key elements, and I'll be ready to take some questions if there are any. Muito obrigado.
Thank you, Professor Kai, for excellent presentation. Unfortunately, you are not real here in Brazil, Rio de Janeiro, because of a visa issue.
Yes.
So sorry about that, but we know there are some problems with the country where we live nowadays, but as organization of the World Congress of Trauma and the Emergency Leagues, I hope you can join us in the next edition in Doha, Qatar next year. And our president, forget about him. Sorry. Forget.
Well, I tried to apply, side note, and the fastest way to get the Brazilian visa was 45 days. So it's irrelevant, but I renewed my German passport, so moving forward, it should not be an issue.
Excellent. So you work in a country where you have a very well mature, organized trauma system. And as work as an orthopedic surgeon, you have the connection with the trauma surgeons, the other specialists. And this symposium at Academia Nacional de Medicina was exactly to put the different specialties at the multidisciplinar approach. And there are so many discussions about education, undergraduate education, and postgraduate through the residence, medical residence. What do you think in the future, United States, you have problems to attract the new generation to work at emergency departments because of the lifestyle, the conditions, salary? What do you think? What's the goal for the next year to bring the new generation to work in a trauma center like you have in Tucson, Arizona?
It's a multifold question, obviously, but we actually wrote an article and published that with Professor Fiorelli in the Journal of Personalized Medicine. That was the key elements of postgraduate education in general, in surgery, in orthopedics, and in trauma. And I will send it to you for your review. But some of the key elements that came out of a survey study detailed there is that the newer generation of doctors put life-work balance at a very high priority level. And it's difficult to educate them when they're unavailable, they're post-call, and you have an interesting case in the operating room, and they're saying, well, I'm off. I'll help you tomorrow. Another dynamic that's playing out, the younger generation is hooked on social media, on augmented reality, simulation. So all of these things are entering the post-graduation training process, and they can be helpful, but I would caution that they're not so helpful with clinical judgment. And it's something you can only teach when you put hands on the patient and you're there in the middle of the night and you're putting somebody back together and you go through the emotional stress and learn from that experience how to save somebody's life effectively and how to be prepared for that scenario next in a better state of mind and with a better state of resources. So whether we can attract younger people to go into these kinds of subspecialties will largely depend on which direction our healthcare system takes. We have a system in place where physician reimbursement is being decreased on an annualized basis. Just January 1st, we took another 12% cut, and we're competing, the bright minds are competing whether to go into medicine or whether to go into other areas. I'll give you an example. My own daughter was in medical school for 6 months. She lasted 6 months at Princeton in New Jersey. And she called me up one day and said, Daddy, I can't do this. I go, why not? It's too much time. I don't have any friends. All I do is read books and study. And it will take me 12 years to get to the other end of that. And when I am out, I'm being told what to do, and I don't have any money to pay my loans back. And I couldn't really argue that too much. So she went into economics. And she's working now in San Francisco for a private equity firm, being promoted to vice president. I'm embarrassed to say how much money she's making versus I, as a practicing surgeon with 25 years of experience. Yeah? So that's the context we're in, and I don't know how relevant that is in Brazil. I could imagine that socialized medicine has a similar impact, but what I think the solution moving forward is we have to stop saving money or trying to be more effective or efficacious in resource allocation at the patient-doctor level. That's the wrong approach. We're the ones that are delivering the healthcare. We're not insurance agents. We're not politicians. That has to play out on a different level. and the money has to be spent where it's needed between doctor and patient. And what we observe frequently is that the resources are spent on what I call tertiary or residual revenue cycles. In other words, the company that makes the implant, the company that makes the gloves, the IV fluids, the medicine, they make disproportionately more money and drive revenue and profits home than what is being paid to the people that deliver the care. And there is an ethical dilemma there that we as a society as a whole have to look at.
Excellent, thank you. I think it's very important we work together with the international collaboration to try to save this problem that you have for the future.
If
Why
I may
not?
add,
Why
if I may add, that's the only way to teach the young generation that are so spoiled that, or the patients here that think the US has the worst system in the world. We don't. We have one of the better ones. And the case to make is, look, how is it in other countries? You know, we frequently hear about Sweden as the best example of socialized healthcare. It's worse than in Brazil, if you really look right down to it. And unless you educate each other about those circumstances, you would never know.
Okay, thanks so much for your participation. Professor Fiorelli, you send your dinner by flight. Maybe you arrive tomorrow morning. Thanks so much.
Muito obrigado. E desculpa que eu não pude falar em português, ok?
Obrigado.
Nada.
So let's go for the next presentation. I'd like to invite Professor Michael Moneypenny. He's an anesthetist. He's originally from Scotland, but the last 18 months he has worked in Kenya. And he will talk about the evaluation, professionalism, leadership, and teamwork in medical undergraduates.
Boa noite, senhoras e senhores. Decidi que também darei minha palestra em português. No, I'm only joking. You have such a beautiful language. You don't want me speaking more for 10 minutes in that beautiful language, so I'm going to speak in English. I'd like to thank the President of the National Academy of Medicine, Professor ELIETE BOUSKELA, for having me along. I know it says about medical students, and I've met some very smart medical students here this evening, so I hope you get something from this talk, but it's not just for medical students. It's also hopefully for those of us who are a little bit older. I have no conflicts of interest. A quick overview. I'm going to talk a bit about professionalism, teamwork, safety, in particular psychological safety. What does the professional trauma team member look like, the multidisciplinary team member, and then some next steps. So professionalism, it can be a touchy subject, but I thought I'd go to this website and try and see if there's anything on there on professionalism. It's a big slide, but the top is in Portuguese, the bottom is in English, so you can just read your section. And there are things on there, I think, that are relevant to all of us and relevant to team working as well. It even mentions team working in there, integrity, and also communication skills. So moving on to teamwork. This is the bit that's relevant to medical students. This was my MD that I did in medical education. And this is the chest x-ray that you should never see. Unfortunately, I haven't got the time to go through it. But this is a tension pneumothorax on the right-hand side with the heart moved over to the left and tracheal deviation. It's relevant because this is the chest x-ray that we presented to medical students in my MD, and then we tricked them, but with their permission and ethical approval. We tricked them to say that really we should wait for this chest x-ray. It was going to be 15 to 20 minutes, but we should wait. And we wanted to see whether the medical students, final year medical students, would speak up and say, maybe we should do something about this. So we waited. If they said nothing, then when they decided that really we should do something, the senior doctor decided to put a needle in the left-hand side of the patient's chest. Because he said, inattention pneumothorax, the lung is moved over to the side, that's not resonant. Isn't that right? And we waited to see if the medical student would say anything or not. Some did, many didn't. And those that didn't, we asked them afterwards, we interviewed and said, why didn't you say? Some said they didn't know, which is maybe true, but I'm worried they're final year medical students. But many said that they didn't feel safe. They didn't feel safe to say anything because this was their boss. And surely the boss knows what's right. So I want to talk about safety and in particular psychological safety. Because I'm in education, I have to give you this slide. It's by law, I have to put Maslow's hierarchy up. And this is just our basic needs. At the very bottom, physiological needs, safety needs, etc. Of course, when I talk to my children, they tell me this is wrong. At the very bottom is Wi-Fi. Have they got access to Wi-Fi before they care about whether there's food or water or anything else? But no, let's get back to this. So safety can be physical safety, safety from harm, for us as well as professionals, safety from being attacked by members of the public, but also psychological safety. And I'm just going to give you this slide from Amy Edmondson, and again, I'll give you the time to read it. And as an anesthetist amongst many surgeons, well, I've spent a number of conversations over the past few days talking about this, about whether it's safe to say to the surgeon. And I remember actually, I had an anesthetic when I was still quite young, many, many years ago now. It was eye surgery. And the surgeon was pulling on a muscle and the patient became very bradycardic. And I gave some atropine and nothing happened. And then I gave some more atropine, still nothing happened. Then I gave a bit more atropine and flushed it through, and the patient became very, very tachycardic. And the surgeon noticed at that stage and said, what's happening? I said, oh, they just became a bit bradycardic. And he said, just tell me next time. And he was right, but I was too scared to speak up. And I think sometimes people think that safety is like this, like the nebulous cloud. It kind of exists maybe somehow, somewhere. But that's not true. Safety can be measured. And as Sidney Dekker tells us, safety is created by us. Safety is not inherent in the system. And in fact, in healthcare, which is complex, with unwell patients being looked after by, at times, unwell doctors and nurses, safety is made by us. What does that mean for us within the trauma team, the multidisciplinary professional trauma team member? How do we help create safety, in particular psychological safety? First, you should admit personal mistakes early. Not just when you make them, of course, I've made a mistake, but before that. Tell the other team members the mistakes you've made in the past, especially if you're a leader within a profession. Tell people the mistakes you've made, because then they will not see you as a god that they feel that they can't speak to you. They will see you as another normal human being who also makes mistakes, and they are much more likely to speak up and tell you, like one of my anesthetic assistants once told me that I was about to inject into the wrong leg. I was distracted talking to a medical student, and I was just about, the patient was still awake, So the patient was not going to stop me, even though the patient knew that this was the wrong leg I was about to put this big needle into. The patient was staying quiet because they trusted me as a doctor. But my assistant said, Michael, that's the wrong leg. And I said, thank you very much, you're right. So admit personal mistakes, accept failure in yourself and others, accept it as a learning moment. I think there's a quote to say that a mistake doesn't become a true mistake until you don't learn from it. And I think, again, it can be difficult for us. I know medical students, maybe there's not this much, but as you go through your career, especially in anesthesia and especially in surgery, the mistakes you make, they come back to haunt you a bit, because the mistakes you make are pretty much immediate often. Usually, maybe the patient was speaking, talking, alive, and then you did something, either with a tube down the throat or in the stomach, or a big scalpel, and now the patient's dead. And it's pretty clear that that was your fault, not the medication, not something else going on. But it's important that even when that happens, you admit that that was a mistake and you learn from it. Make sure you collect opportunities to get feedback. How do you learn? We mentioned at a previous conference that the older you get within medicine, the less feedback you get. When you're a young medical student or a trainee, everybody's giving you feedback. Even whether you want it or not, everybody's pulling you to one side, let me just tell you how bad you are. But as you become a consultant, that doesn't happen anymore. No one tells you how bad you are, unless you create those opportunities. Listen to understand. The mnemonic that I like is called wait. Why am I talking? And so I think every now and again when I'm speaking, I have to think, wait, why am I talking? Why is the trainee not talking or the patient not talking? And lastly, generally thank the people for the feedback or the input they offer. When people give you feedback, and again, maybe for the medical students and for trainees, when people give you feedback, it means they care about you. If they don't, they won't tell you anything. They'll just let you go on your way. But if they've given the time, they've taken the time out of their busy lives to give you feedback, you should thank them for it, even when it's not really what you want to hear. Next steps. What can you do to improve some of the stuff around psychological safety and team working, especially in multidisciplinary teams? I'm going to do a little plug here. So one of the things you can do is the NOTS course. There are many, many other courses, of course, that we just heard about today, the non-technical skills for surgeons, because it talks about this. And then the second thing I can offer to you is to use simulation. It will never replace clinical practice. You cannot replace clinical practice with simulation. But what you can do in simulation is that you can create those scenarios that you don't really want to see in clinical practice. Maybe you create the scenario where the surgeon is shouting or the anesthetist is asleep or that kind of thing, and then you can talk about that in a safe way. You don't need to wait until the hemorrhaging patient comes in or the polytrauma comes in, and then you realize your teamwork is actually terrible because no one wants to speak to each other. It's much safer to do a simulation, realize that the teamwork is not good, and then improve on it. Thank you very much for listening.
Thank you, Professor Michael. So for the next presentation, I'd like to invite Dinka Lulic. She is an emergency physician. She is from Croatia, but the last 3 years she has worked in Malta. And she'll talk about the emergency physician, the experience in Europe.
Good evening. I would like to thank the organizers and Madam President for inviting me to be here tonight with you. I would also like to express my sincere gratitude and congratulations to Professor Gustavo and Andrea Fraga for all the organization and success with all the events that happened in the last 1 to 2 weeks in all sides of Brazil. So my name is Dinka. I'm an emergency medicine specialist from Croatia. I currently work in Malta, but my residency training program I did in Croatia at University Hospital Center. In the last 2 to 3 decades, emergency medicine has significantly evolved in Europe. Back in the day, and unfortunately in some other countries in Europe, also in the world, emergency departments are still run by specialists from different specialties like surgery, anesthesia, ICU, internal medicine, without formal training in emergency medicine. But there has been a shift in recognizing and developing emergency medicine as a specialty, because by the experience, by the time physicians realize that there is a specific need for physicians dedicated to very unique treatment in emergency departments. So, emergency medicine is a very young specialty in Europe. In 1970s, 1980s, British realized and recognized that there is the need for individual specialty in emergency medicine. But from the initial idea and recognition, it took them about 20 years to formally develop emergency medicine specialty. The first specialty in emergency medicine started in Iceland in 1992, and then a year later in UK. Most of the countries, European countries, started with emergency medicine residency late 90s, early thousands. The big change, the turning point happened in 1994 when European Society for Emergency Medicine was created. The society that managed to put the standard of training and management of the patients in emergency department. They had a clear vision. They were trying to give a standardization of emergency medicine in most of the European countries. Their idea, their goal at the beginning was by the 2020 to develop emergency medicine specialty in more than 20 countries. And their idea was very successful. By now, by the data from 2024, there have been 33 countries in Europe that recognize emergency medicine as a specialty. We can say that emergency medicine specialty is one of the fast-growing specialties in Europe. Out of all these 33 countries, only 16 countries have emergency medicine as a primary specialty. This means that they are having a 5-year residency that follows USEM curriculum. There are other countries that have, they call them super specialties. Basically, these are physicians from, example, internal medicine that did 1 or 2 year additional specialty training in emergency. So they are not official emergency medicine specialties, but they are kind of trying to follow the USEM curriculum. as I told you, I finished my residency in Croatia. Croatia recognized emergency medicine as specialty in 2009, and then it took them 3 years to establish proper emergency departments. And our first specialists started their training in 2012. This is me. This is actually, I cannot believe that I found this, but this is my picture of the first day as an emergency medicine resident. Don't ask me how I ended up in EMS, ambulance car. I don't know, but I know that this is me on my way to work. As you can see, I'm very young, happy, enthusiastic, eager to learn, to train. Little did I know what the roller coaster of next 5 years are gonna be. Back in the day, so this was 2014, in my hospital we had 3 emergency medicine residents. When we came, nobody actually knew what to do with us, right? Our emergency department was run by specialists from surgery, different parts of surgery, anesthetists, ICUs, and internal medicine specialists. So we were kind of trying to find our way. We learned from all of these specialists, besides these major ones, also neurologists, pediatricians, ENTs, ophthalmology, gynae. But it was always very subspecialist training that they provided us. And we were kind of trying to find our own way, to get bits and pieces of all, and then develop our own way of working in emergency departments, because we didn't have a role models. There were no emergency medicine specialists in Croatia back then. So it was a rough time. But I can say that we kind of managed to completely transform our emergency department within these 5 years. At the end of our residency training, we had my residency training, we had 6 of us, emergency medicine specialists. So, but we really managed to transform the patient care in our emergency departments. In most European countries, I cannot go into details because all of the countries are not running the specialty in the same way, right? So, but in most of the countries, at least in the countries who are following USEM curriculum, we are trained to work as physicians in hospital emergency departments, to be able to work in observation and high dependency units, and also to work as physicians in emergency medical services or helicopter emergency medical services if you are in the country where they have EMS, which are physician-based. Of course, USEM was trying to, they developed European core curriculum and European training requirements, which every emergency medicine specialty should follow. This would mean that besides working in emergency departments, which was 60 or 70% of our time, we had rotations in different wards, surgical, pediatric, internal medicine, most generalized internal medicine wards, ENT, ophthalmology, gynae, all ICUs, so surgical, internal, in Croatia, in our hospital, we had gastro ICU, cardiac, so we had divided ICUs, and also we had rotations in the ORs. The core competencies by USEM of all emergency medicine specialists should be to be able to work as a good team leader and to be able to work in good teams. Other than that, clinical decision-making and invasive and non-invasive procedures. By the end of our residency, we were trained in doing from basic to advanced airway maneuvers, surgical airways, placing chest tube drains, vascular access like intraosseous, intra-arterial lines, cervical lines. We were also managing mini operations, how we used to call them, incision and drainages, etc. So we did lots of invasive and non-invasive procedures in our emergency departments. Of course, we were not the experts, but we tried our best. We are all, no matter of the specialty, under constant clinical pressure, trying to kind of have a balance between with academic work, research, teaching. All of these is one of the most important things in our development. Trying to find a balance between the, give me a second. Trying to find a balance between clinical practice and career development is something we all are trying to master in. Besides other specialty, emergency medicine environments are very specific, right? We were struggling, and we are still struggling with variability and recognition. I mean, there are many more countries in Europe and all over the world that don't recognize emergency medicine as a specialty. They don't see the point of emergency medicine specialists. There is, although there is the idea of standardized training, there is no, you cannot have a standardized training in all the countries, in all the hospitals. There is a huge shortage of emergency medicine specialists. I know when we started, there was a gap of 2 years when nobody applied for the specialty. Burnout and stress due to heavy hours, long hours, overcrowded EDs. And one of the most important things is low funding. There are no resources put for training in emergency departments. I think that continuous training is something that is one of the most important things for clinical and non-clinical excellence. Excellence in medicine should not have any boundaries or any borders. I was lucky enough to be able to train, to go to congresses, conferences, simulation workshops all over Europe and the world. Some of my mentors are here, like Professor Carlos Mesquita, Enrique Alexandrino, Gustavo Fraga. I learned a lot from them, and I wouldn't be here where I am without their support. And at the end, I mean, emergency medicine is not a specialty, it's a calling, I would say. It's something you choose. It's something where you have to be very brave, very calm, very have clarity in the most stressful situations. And I hope in the next few years, maybe I will listen to one of your talks about development of emergency medicine in Brazil. Thank you so much.
Thank you, Jinka. So I'd like to invite Dr. Anders Rubiano. Dr. Anders, he's originally from Colombia. When I met him the first time, 2006, he was a visiting professor at the University of Campinas. You're young, 19 years ago, and he was from Neiva. But after this, he went to Pittsburgh, worked some years in Pittsburgh, and now he came back to Bogotá, the Universidade El Bosque in Bogotá, Colombia. And he's director of the Global Neuro, and he organized a guideline, a bootstrap about neurotrauma, traumatic brain injury, the last 2 days at Brazilian Society of Anesthetists. And tomorrow he organized a course for undergraduate students about neurotrauma. Thanks so much, Dr. Rubiano.
Thank you so much, Professor Fraga, and thank you to the leadership of the Brazilian Academy. I think this is a great opportunity to share the experience that we have been developing from South America and from Latin America to the world related to neurotrauma care and what we have been advancing on in specific parceria and support with some colleagues from Brazil. There are so many entities that have been working with us. I want to highlight the Latin American Federation of Neurosurgical Societies with the Neurotraumatology and Intensive Care chapter, and also the World Federation of Neurosurgical Societies with the Neurotraumatology Committee, with other entities, and our research centers in Colombia that is called Meditech Foundation. Thanks again to the members of the Academy, especially to Professor Bouskela and the academics, Dr. Camargo, Fiorelli, and Dr. Fraga, obviously, for this kind invitation. When we talk about neurotrauma, there is a high burden related to this aspect worldwide. These are some of the works that we have been doing with a specific group, that is the group from the Global Health Program at the University of Harvard. We have been working into the dynamics of the problem and understanding that there are a lot of missing data related to these aspects worldwide. We understand very well that this problem is commonly affected in general, all the countries. But what happened is that the severity of the disease is more pronounced in LMICs and in areas like Latin America. Dominican Republic, Brazil, Colombia are countries that are heavily impacted by this condition, especially due to motor vehicle accidents and social violence. With our group, we have been studying several aspects related to the management of this condition in regions with limited resources. And we also have been able to understand the correlation between those epidemiological aspects and the situation, especially in spinal cord injury and traumatic brain injury. When we have these patients worldwide, these patients can arrive to a several heterogeneity of centers. We can have severe TBI patients in centers that do not have too many resources or even does not have training, or we can have these patients in very advanced centers with all the resources, but this is not the most common situation. If we go globally, these are some parts of the study that we have been doing related to a spinal cord injury worldwide. And we understand that many patients arrive very late, especially in the African region, some in the Latin American region, and also most of the interventions that are commonly taught in many of the courses cannot be followed in many areas due to the constraint of resources. When we talk about guidelines, consensus, and protocols, we all know that there are several entities, associations, groups that are developing this type of exercises worldwide. But what happened is that we take many of these recommendations and we are gonna apply that directly to the field. There are several barriers. I just want to give you an example also in spinal cord injury with some of the work that we have been doing is when we talk about awareness of many of the published guidelines, there are several regions of the world that even does not are aware of that, or they do not have how to apply these guidelines because of the constraint of resources or the limitations in education. There are obviously economic barriers, like for example, in Africa, around 75% of the population that sustain a spinal cord injury need to pay by their own pocket the initial image. So it's very difficult to have patients that can have an early image in order to take decisions for surgery. So what we developed from LATAM since some years ago was something that is called the Stratified Protocols Projects. The Stratified Protocols Projects are looking for, try to support in some part these disparities that are when you take care of the patients. So what we have done is developing a specific protocol for real world scenarios understanding that in some places, there are, for example, pre-hospital teams that do not have any resources or training, but even there, you can do some basic management that can be recommended in those conditions. You can also have medium levels of care and very advanced levels of care, even within the same countries. When you move from that scenario from pre-hospital, you can arrive to an emergency room that can or cannot have a CT. You know, CT is a very specific tool for defining management of neurotrauma patients, but there are several centers around the world that do not have access to an early CT. I just can bring you an example. We were working with some countries in the Latin American region, and for example, a very busy trauma center from Lima in Peru was around more than 6 months without a CT in place because it was broken and there was no way to help them to do that. So you can imagine if you are in a referral center but your CT is broken, how are you gonna manage your patients? So all these situations are situations from the real world. Sometimes you can operate the patient, but you don't have ICU bed available because mostly some beds are occupied by other type of patients. So what we do in 2018 was to bring together many different providers of care from the Colombian regions, including the Amazonian, the most limited resources regions, but also the high wealthy centers in the main capitals. But we pull up them together to develop this set of different protocols for each one of these scenarios. So we were pretty successful. We published this later on with a lot of difficulties because many of the reviewers were from Europe or the United States. And I remember very well a reviewer from Europe saying, why are you want to publish a protocol for managing TBI patients if you don't have CT? That's not possible. And obviously, it's not possible in an area that you have all the resources, but what happened in the areas that you don't have the resources? So around 3 years after, we were able to publish the whole process. And this is guided by a colors code. When, for example, if you see the first algorithm that is in the upper part of the slide, if you are in a very basic transport vehicle without training, without resources, you only need to follow the red interventions. If you have some more resources, you can move into the yellow ones. And if you are in a very advanced center, you do the vehicle, you do the red, the green, and the yellow ones. And this is the same for emergency room, for neurosurgery, and for ICU. This has come attention in several regions. This is the same exercise that we did last year in Peru. This is the same exercise that we did this year in Ecuador. This is the same exercise that we did this year in Paraguay. And a couple of days ago, we have been working in this same exercise in Brazil. It has become pretty successful. We already have requested for areas like India and other countries in the region. And we really think that this could be a really great initiative to show to the world. Obviously, we can propose anything in the paper, but we need to prove if that works in the real scenario. So this is unpublished data for the first study that we did with the applications and dissemination of this type of protocols in some centers in Colombia, very different centers from the Amazonian region, from the Andean region, and from the Pacific region. And in general, if you generate good adherence to the protocols, the mortality was reduced from 42% to 29%. And it's totally attached to the adherence of the protocol. As you have more adherence, you reduce more the mortality. If you have less adherence, you increase the mortality. So it's something that we are going to publish soon. And obviously, in many of the other countries that we are working on, we will be doing or proposing to do the same studies. This is the same exercise for a spinal cord injury. We did that a few years ago. This exercise was more globally associated with the support of the World Federation of Neurosurgical Societies. The good point with this is that these are protocols that you can update over the time according if more resources are arriving to the field. This is just a brief example of that. Now we are using a lot of non-invasive devices since the emergency department can be used since the ambulance to understand if a patient has an intracranial hypertension without a CT. So many of these tools are already in place in many countries and inclusive in the Latin American region. So we just add to a recent update of the protocol that we did. Also, you know, biomarkers are coming in an important way. And all these are changing in a way that now the classification for severity of TBI is changing. So we will not rely anymore just based in the Glasgow exam. That is also attached to a possibility to use early biomarkers at the same way that we use that in coronary disease. So we are in a new era of guidelines and protocol, and this has been a collaboration that now have more people on board. The American College of Surgeons and many other entities has been attached to what we are doing, and they are really interested in continue doing this work in several regions. Finishing, I just want to mention that obviously it's pretty important to collect data. This is the Latino project. It's a Latin American and Caribbean registry for neurotrauma. Now we have around 3,000 patients for around 8 or 9 centers from the region, including 2 hospitals from Brazil. And we still does not publish any data from this registry, but soon we are gonna start doing the first iteration of analysis of this data. And also, as has been discussed in these minutes and hours, it's pretty important to get attached to the training of the people. This is one of the few neurotrauma fellowship programs outside high-income settings. We have this program supported with a multilateral collaboration since around 10 or more years ago. And we have a really good interaction with Brazilian neurosurgeons that are also very motivated for doing neurotrauma care. We have some pictures here from Dr. Robson Amorim, the current president of the Brazilian Academy of Neurosurgery, Dr. Rui Monteiro from the Hospital Miguel Couto here in Rio de Janeiro, Dr. Wellington Paiva from University of Sao Paulo. So there is a lot of people that is actually collaborating with this exercise. And fortunately, I think for the end of the year or next year, we are gonna have a similar process for the University of Sao Paulo in a collaboration with our program. The University of Cambridge has been very supportive. Also, the Rockefeller Neuroscience Institute at West Virginia University. And we have now trained more than 11 fellows, mostly from Colombia, Venezuela, Brazil, Dominican Republic, and including Pakistan. Now we are receiving requests from many other regions, especially in LMICs. We have been supporting the training of more than 100 residents in different fields like general surgery, neurosurgery, anesthesia, emergency medicine, and intensive care. And we have trained more than 150 medical students from all regions of the world. So this is possible, it's coming from our region because, as was mentioned, we have the patients. Most of the patients are in our region, you know, and this severity allow us to really go and move into the direction of really learn how to deal with these patients. This is an open invitation for the International Neurotrauma Society Symposium. It's the first time that is be sustained outside Europe or United States. It's gonna be in Cartagena, Colombia on October 22nd of 2026, and you are all invited. Thank you so much.
Thank you, Dr. Rubiano, and congratulations for your work put together, not only Latin America, but all the world in neurotrauma. And the next presentation, I'd like to invite Dr. Frederico Arnaud. He's an emergency medicine physician. He's from Fortaleza, Ceará. He has a long history about the introduction of the emergency medicine as a specialty in Brazil. And he'll talk about the emergency physician, the experience in our country. Thank you, Dr. Fred Arnaud.
Boa noite a todos. Espero que estejam todos firmes, porque eu tenho 150 slides para passar para vocês. Brincadeira. Primeiro, cumprimentar a presidente dessa instituição, doutora ELIETE. Prazer estar aqui. Cumprimento todo o restante dos presentes. Queria agradecer também, em especial, a todos que organizaram esse evento, e em especial ao professor Gustavo, Fraga, que além de um organizador de primeira linha, é um anfitrião de alto gabarito. Estivemos em 3 eventos sequenciais essa semana, e ele se mostrou um alto e importante anfitrião. Bom, o que eu trago para vocês aqui é algo que já aconteceu. Prestem atenção, todos, porque eu talvez tenha aqui algumas respostas, várias perguntas que foram feitas durante essa tarde. Durante essa tarde, eu senti um misto de emoções muito intensas, misturado o alívio e a felicidade e também a angústia dos colegas cirurgiões de trauma que estão lutando por um projeto que deve ser respeitado e que eu tenho certeza que será vitorioso nos próximos dias. Estamos entrando num campo onde o conhecimento técnico aliado à ação imediata pode definir a vida ou a morte do ser humano. Não há nenhuma especialidade na medicina que haja uma relação tão intensa entre a prática e a teoria. É formidável. Eu costumo dizer que a medicina de emergência é a especialidade mais extraordinária da ciência médica. Eu poderia apresentar aí, me apresentar como vários adjetivos: diretor, presidente, escritor, doutor, mas tem algo que me define, que é a medicina de emergência. Então, muito prazer, meu nome é Frederico Arnaud, eu sou médico emergencista. E ela tem uma definição bem clara. A ACEP, Associação Americana de Médicos de Emergência, define a medicina de emergência como essa especialidade extraordinária que atende todas as patologias, todas aquelas patologias agudas e graves, ou as crônicas agonizadas que vão levar a risco de morte às pessoas. Algumas características são importantes demais. A prioridade, a rapidez, pensar rápido. Muitas vezes não dá nem para ir nos apps para fazer alguma ação. Isso está muito bem evidenciado na literatura. São um trabalho de mais de 400 trabalhos mostrando a importância da medicina de emergência como especialidade médica. Aonde, hoje, que são mais de 80 países que ela é uma especialidade, como melhorou o sistema de saúde, como melhorou a função do médico, como melhorou a atendimento para as pessoas. A redução de mortalidade foi importantíssima, desde os anos 30, lá nos Estados Unidos, quando a medicina de emergência se tornou também uma especialidade, há mais de 30 anos. Médicos emergencistas são custo-eficazes. E aí eu quero que vocês façam o paralelo com o que foi dito tudo hoje aqui sobre o cirurgião de trauma. É um paralelo igual. São médicos eficazes, médicos que vão internar pessoas que necessitam, não vão internar o que necessitam, vão pedir os exames que são necessários, não pedir os exames que não são necessários. Isso está bem comprovado na literatura médica. E um pouco da história do Brasil. Apesar dessa definição, um pouquinho da história do Brasil. A primeira sociedade, eu tenho muito prazer em apresentar para todos os senhores, a primeira sociedade médica relacionada à medicina de emergência do Brasil é do nosso Ceará. Um estado pioneiro em várias opções, em vários momentos. Foi o estado que primeiro libertou os escravos no Brasil e entre outras coisas. Também teve a primeira sociedade que chamava-se SOCEMO, Sociedade Cearense de Medicina de Emergência, que foi fundada pelo médico Henrique Mota, nesse tempo aí, em 85, mas ficou hibernando. E em 1998, eu e um grupo de colegas de Fortaleza, com o doutor Lindenberg Lima aí, e outros que não estão aparecendo aí, resolvemos ativá-la, reaquecê-la. E aí começa uma grande história de vitória que vou passar para vocês rapidamente aqui. Não sei nem como é possível fazer isso, mas vamos fazê-lo. Em 1996, foi importante, foi realizada a primeira residência médica em medicina de emergência lá no Rio Grande do Sul, para o doutor Luiz Alexandre. E também fizeram a primeira associação, que era a associação tipo a SOCEMO no Ceará. Então, foram fatos importantes que aconteceram. E em 2007, foi um fato fundamental para que hoje tivesse a medicina de emergência como especialidade. Pessoas que não se conheciam, de São Paulo, Rio de Janeiro, Fortaleza, se encontraram no primeiro Congresso Brasileiro de Medicina de Emergência em Gramado, em 2007. E lá foi muito interessante, eu tenho sempre que contar isso, porque acho que as ligações divinas são importantes, e as neurotransmissores trabalharam bastante. Como é que eu fui parar aí? Eu recebi um telefonema de um colega do Rio Grande do Sul, dizendo, doutor Fred, nós queremos convidar o senhor para participar de um congresso aqui em Gramado. Eu digo, que legal, quero. Nós estamos aqui há quase alguns anos lutando pela medicina de emergência, já fizemos mais palestras e congressos e jornadas que fizeram nos últimos 20 anos antes da reativação da SOCEM. E ele disse, não, eu estava aqui em Buenos Aires falando com um australiano, o Dr. Peter Camargo, talvez algum dos estrangeiros conheçam, uma personalidade mundial na medicina de emergência, e eu fui falar para ele que só existia medicina de emergência no Brasil, no Rio Grande do Sul. E ele disse, não, tem também no Nordeste do Brasil. No Nordeste do Brasil tem um grupo lá, mexendo, se movimentando, fazendo a medicina de emergência acontecer. O que foi que aconteceu? Em 2007, eu passei um mês em Melbourne e conheci esse cidadão lá, e ele passou. Então, veja as ligações. Um gaúcho falando com um australiano, em argentino, ligando para o Ceará. Veja as conexões aí, como foram sensacionais, né? Então, participamos aí ativamente, e daí sai a proposta da formação da Abramed. A Abramed hoje é a Associação Brasileira de Medicina de Emergência, que fundamos numa quinta tarde lá no HPS de Porto Alegre. Estou ali, o doutor Luiz Alexandre de Paletó, ao lado, foi um grande, outro colega importante nessa luta toda, e lá uma quarta tarde nós fundamos aí a Abramed, e até hoje ele me deve um churrasco, porque quando ele me convidou, eu pensei que ele ia fazer um churrasco gaúcho, né? A gente pensa em churrasco, mas realmente só saiu Coca-Cola e uns bolinhos ali, até hoje ele me deve esse congresso. Mas estava fundada a medicina de emergência. Saio daquele congresso lá do Gramado com duas propostas, com duas promessas. Quando eu chegar em Fortaleza, eu vou fundar uma residência igual a de vocês, que a gente não sabia que existia residência, a gente não sabia que tinha outra associação falando sobre medicina de emergência. Fundamos aí, por decreto, a segunda residência do país, em 2008, lá em Fortaleza. Já estamos aí na 50ª turma, já bem avançado, aí formamos mais de 100 profissionais já. E o segundo papel foi o segundo congresso. Fizemos o segundo Congresso Brasileiro de Medicina de Emergência, e vocês vão ver que vai haver um crescente. Naquele primeiro congresso tinha 500 pessoas, esse congresso tinha 1.500, um congresso de sucesso, de crítica de público. Depois vieram vários outros congressos, 2011, 2003, 2016, São Paulo, Curitiba e Porto Alegre, voltou para o Rio Grande do Sul. E aí eu saí numa seara de visitar o Brasil todo, visitei Alagoas, Amazonas, Acre, Piauí, fui ao Haiti como voluntário naquele terremoto de 2010, para divulgar a medicina de emergência como especialidade. E aí começa a haver a parte mais institucional. Agora, os conselhos regionais, os Conselhos Federal de Medicina nos chamam para conversar sobre o que é isso, o que é essa proposta da formação da medicina de emergência como especialidade. Então, tivemos aí no fórum no Rio Grande do Sul, um fórum em Brasília, no Regional de Brasília. O Conselho Federal fez 3 fóruns nacionais para discutir a medicina de emergência como especialidade, e eu trouxe o segundo, porque aqui nasce a medicina de emergência como especialidade no Brasil. E eu tive o privilégio histórico de ser o representante, nesse momento, de fazer a defesa da medicina de emergência como especialidade. Foi uma assembleia onde todo o Brasil estava representado, e eu tinha que dizer por que sou a favor, e um grupo que não entendia por que a medicina de emergência devia ser uma especialidade no Brasil, foi lá dizer por que era contra. E eu acho que nós ganhamos esse debate, porque, da primeira vez, o Conselho Federal de Medicina passa um documento dizendo que tanto aprova como pede que as outras instituições também aprovem a medicina de emergência como especialidade. Para quem não sabe, no Brasil existe uma comissão mista de especialidades, que é quem cria a especialidade. 2 votos da AMB, 2 votos do Conselho Nacional de Residência e 2 votos do Conselho Federal de Medicina. Você tem que ter os 6 votos unânime. Se tiver um contra, morreu. Então, já tínhamos ganho 2 pontos aí, vamos para frente. E aí, quando em 2015, por nossa surpresa maior, pensávamos que iam demorar mais, é anunciada a medicina de emergência como especialidade. Depois de 3 fóruns nacionais, depois de vários debates, depois de processos, depois de briga, depois de luta, com as pessoas que não entendiam e não compreendiam a medicina de emergência como uma especialidade. Está aí no número 29, eu sempre boto uma seta para ver se ninguém tirou, porque ainda tentaram tirar depois na justiça, mas nós ganhamos finalmente e ninguém mexe mais na medicina de emergência no Brasil. E aí deu fantástico, né? Um programa, quem quiser ver, pega lá aí nas mídias, fantástico, 15 minutos do maior programa de televisão, da maior audiência do Brasil, à noite, 7 minutos falando sobre a medicina de emergência como especialidade. Mas nem tudo estava vencido. Quando a gente pensa que está tudo bem, a oposição que nós tivemos durante 15, 20 anos para a medicina de emergência não ser uma especialidade, agora queria assumir o papel de gerente dessa especialidade, dessa nova especialidade. Começa mais uma nova briga, e aí a MB vai ter que definir quem é que vai comandar os caminhos da medicina de emergência nos próximos anos. E aí deu bronca, o doutor Luiz Alexandre, o grande guerreiro comigo, junto dessa luta toda. Mas não podia ser diferente, a verdade sempre vence. A verdade, ela é imprescindível e nunca vai deixar de vencer. E aí, Luiz Alexandre e eu saindo da reunião da AMB, onde tivemos que apresentar de novo um protocolo, convencer a todos os 53 especialidades que tinha naquele momento, e depois uma votação, para ver se a medicina de emergência se transformava em especialidade médica. E aí, saímos vitoriosos mais uma vez. Esse é o congresso de 2018 em Fortaleza, com 4.000 pessoas, um congresso de público e crítica muito importante, e eu saio agora aí, era presidente da Abramed nesse momento, saio, me despeço da Abramed e dão continuidade a esse projeto maravilhoso que é transformar a medicina de emergência em especialidade. Aí veio outros congressos, né? Teve a pandemia, e voltamos em 2024, e agora? E agora é estudar, 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 até sangrar. Nós estamos aí com 1.000 profissionais sendo treinados nesse momento em todo o Brasil, com quase, se eu não me engano, 80 residências no Brasil. Esses meninos estão fazendo a diferença. Está aí os treinamentos, aqui em Fortaleza, logicamente, uma das pioneiras. Aqui nossa sala ao ar livre, a maior sala ao ar livre do mundo. Nós estamos treinando exaustivamente esses profissionais, 3 anos de duração, seja aí no pré-hospitalar, no hospitalar, e aí nós estamos vencendo essa batalha há 10 anos, vamos fazer 10 anos agora no próximo ano, e eu queria apresentar para vocês a doutora Camila, que é a nossa presidente atual da Associação Brasileira de Medicina de Emergência, que está aí segurando a camisa ao centro, né? E quem quiser saber detalhes dessa história, eu lancei o livro Emergência Já, Amor para Sempre, Medicina de Emergência no Brasil, está aí no Amazon, vocês podem comprar, façam esse favor, que me ajuda muito. Estarei aí nos nossos contatos aí, do Frederico Arnaud, no Emergência Já. E eu quero deixar uma mensagem final. Cirurgia do trauma já, amor para sempre, assim como eu dizia, emergência já, amor para sempre. Precisamos modificar o cenário atual das nossas emergências em todas as suas características, seja com médico emergencista, seja com cirurgião de trauma, e isso nós vamos melhorar bastante e reduzir a mortalidade das pessoas que não deveriam morrer nas nossas emergências. Muito obrigado. Foi no tempo, né?
Professor Antônio Martos, da Universidade de Miami, hoje é o chefe médico do Grand Prix da Fórmula 1, está em Interlagos e gravou um vídeo para ser apresentado. Janilson, por favor.
Prezados, professor Rossano Fiorelli, prezados acadêmicos, Academia Nacional de Medicina, eu queria me desculpar por não estar presente hoje pessoalmente no evento, esse grande evento, falando sobre cirurgia de trauma. Estamos aqui em Interlagos, fazendo treinamento para mais uma etapa do campeonato de Endurance da UEC, a FIA, os carros correm Le Mans. Estamos tendo aqui agora o simulado. E, na verdade, durante o simulado, a resposta a uma emergência, um trauma, um motorsport, como que a gente faz para realmente tirar um piloto da forma mais segura. Esses carros aqui podem ter um impacto grande, carros com energia, né? Muitos deles são híbridos. Então, treinamento, da mesma forma aqui na sala de trauma, no pré-hospitalar, que assim, no treinamento do automobilismo, é uma situação de alto estresse, que a equipe tem que estar treinada, capacitada, é isso que nós fazemos. Essa é uma corrida de endurance, da mesma forma nós fazemos na Fórmula 1 em Miami, Fórmula 1 em Las Vegas e na Fórmula 1 aqui em Interlagos. Então, desculpe não estar presente com vocês, mas estamos aqui observando e vendo como a equipe local está participando desse treinamento, e durante a corrida vamos estar na pista do carro médico junto ao Dr. Dino Altman, que participou do último evento da Academia Nacional de Medicina. Juntos aqui, mais uma vez, nosso país, nosso Brasil, participando desse treinamento. Ok, muito obrigado, parabéns pelo grande evento e espero que vocês tenham tido o máximo proveito dessas palestras de grande qualidade, como sempre. Muito obrigado, forte abraço.
Então, vamos passar a palavra para o primeiro comentarista da noite, professor Pedro Portari, da Unirio, atual presidente do Colégio Brasileiro de Cirurgiões.
Boa noite a todos. Agradecer a nossa presidente da Academia Nacional de Medicina pelo convite, junto com meu querido amigo e colega de departamento, professor Rossano. Nice lectures that we saw. Mr. Moneypenny, I have one question for you. I like very much your lecture. So much philosophy, but do you believe that our new students, medicine students of this generation, understand these concepts that you show us and they use in their practice, dire practice? You really believe that all that you show us, our new students, this generation is apt to understand and work with that?
Thank you very much for the question. Just to confirm, would new students understand these concepts? Is that the question, or?
It's a question.
Yeah. Okay.
Yes.
I don't know. I guess partly I might ask the students, but I think some of the problem is not, or the challenge is not students. It's the people of my age and older, maybe, who believe that the way they were treated was the way they should treat others. That throwing the scalpel in the operating theater is acceptable behavior. Tim was telling me about a consultant who got his pen out, clicked it, and then stabbed him in the chest with it to remind him not to forget something. So I think the challenge is maybe the older generation, not the students so much. And I also think it is a learned behavior. They are skills that we learn. Some people takes a bit longer than others, but I have great hope for the new students, because they're, as Gustavo says, they're going to be the people who are looking after me and looking after you. Thank you.
Nós temos poucos estudantes novos ali, a turma já foi, mas acho que uma das grandes lições que a gente teve hoje é que a medicina de emergência, cirurgia do trauma, primeiro é um trabalho de time, né? Sem time não vai. Segundo, é um trabalho que realmente necessita de você ter lideranças, capacitação, e você ter a turma jovem entendendo quanto isso é importante. A primeira palestra do nosso convidado americano falou sobre a disposição dos centros de traumas americanos. Acho que todos nós, né, Gustavo, entendemos que é isso que falta no Brasil. Eu acho que a gente tem que modificar esse raciocínio. Enquanto o país não entender que medicina de emergência e trauma é política de governo, política de Estado, eu acho que a gente vai ter muita dificuldade. E não temos dúvidas, todos nós, de todas as áreas, que é um trabalho árduo, mas um trabalho que tem que ser concentrado em capacitação, em residência médica específica, como na medicina de emergência, também na cirurgia do trauma, que está passando para 2 anos agora, mas principalmente a gente fazer no Brasil, copiar ou estruturar experiências que a gente tem visto nos Estados Unidos, principalmente, que é a criação de centros capacitadores, centros assistenciais, centros de pesquisa, com as suas tipos de qualificação, de acordo com a possibilidade e a disponibilidade. Enquanto nós não formos capazes de fazer com que isso vire uma política da medicina do país, pública, eu acho que a gente vai continuar discutindo belíssimamente, como a gente esteve aqui hoje à tarde, mas acho que esse é o nosso norte, né? Acho que é isso. Obrigado.
Eu gostaria de complementar o que o doutor Pedro Portari disse no seguinte sentido. Eu acho que aqui no Brasil nós somos muito mal em planejamento, muito maus planejadores. A gente não planeja nada. Então, eu tive uma discussão, eu estou numa discussão agora a respeito de ensino médico, e a discussão é o seguinte, é porque não se consegue fechar nada. E eu conversei com o ministro Padilha, e ele me disse, não, mas nós vamos agora avaliar as faculdades de medicina. Aí a minha pergunta para ele foi a seguinte, mas essa avaliação vai ter consequências? Porque se não tiver consequências, é melhor não avaliar. Então, eu acho que hoje, por exemplo, uma coisa que nós sempre fomos muito bons aqui no Brasil é vacina, nós não somos mais. Então, eu acho que a gente tem que pensar seriamente, nós não somos bons em prevenção de doença, nós não somos bons, obviamente, em prevenção de acidentes, nós não somos, a gente não consegue prevenir, a gente consegue talvez agir. Nós temos bons médicos, bons profissionais. Agora, estamos formando maus médicos, porque nós temos faculdades de medicina que não têm condições mínimas de funcionamento. Existem vagas ociosas na residência, porque as pessoas não estão fazendo residência, e o grande problema é que não se fecha nada. Então, eu acho que nós, da Academia Nacional de Medicina, junto com as entidades médicas, temos que propor essa política de Estado, que nós temos que ter consequências naquilo que a gente está fazendo. Porque se não tem consequências, então não adianta. E, por exemplo, recentemente eu li uma coluna no jornal O Globo, que é o jornal que eu leio mais ou menos frequentemente, dizendo o seguinte, que o ProUni forma 2.600.000 advogados. Agora não forma engenheiros. Nós não formamos engenheiros nesse país. Junto com o fato da gente não ter essa programação de medicina, o Brasil não vai para frente se não formar engenheiros. Eu não sou engenheira, mas eu acho que qualquer pessoa entende isso. E nós hoje temos mais advogados do que a China tem. Não pode ser razoável. Não pode ser razoável. Então, eu acho que nós temos que discutir, durante o intervalo, eu discuti que nós temos, com a Academia Nacional de Medicina, no alto dos 196 anos, nós temos que sair da Torre de Marfim e começar a colocar coisas para o governo, qualquer governo, que são necessárias para o Brasil, sem ser penduricalhos, porque não adianta esse programa de mais médicos, por exemplo, de médicos no interior, Se a cidade do interior não oferecer condições de trabalho a esse médico, condição de trabalho para o cônjuge do médico e escola para as crianças, o médico não vai ficar ali. Então, isso passa a ser uma brincadeira, mais despesas e não vamos a lugar nenhum. Então, eu acho que eu gostaria, I would like very much to thank deeply all the international speakers, because you gave us a very good view of what is possible to do. And I'm just complaining that in Brazil, sometimes we don't evaluate, and when we evaluate, we don't follow this other step, which are the consequences of the evaluation. But I would like very much to thank you, because if we don't know what's going on or what is possible to do, it's very difficult to come up with ideas. So I think this symposium today gave us a lot of ideas that we could work on and continue to press the Minister of Health, the Minister of Education, and the government itself to see what can be done better for the Brazilian population. Thank you very much.
Sometimes I'm happy because our international faculty, they don't understand Portuguese, except Dr. Carlos Mesquita and Dr. Henrique Alexandrino. Because you have been, some professors, like Professor Ari de Paniem, arrived in Brasilia on July 26th to teach in the STC course. He has been here the last 11 years, and this is a very complex country. You cannot understand how Brazil has the highest number of medical schools. It's very difficult to us to explain to them. You cannot understand someone like Dr. Rubiano, experience he has in neurotrauma, visited us 19 years ago. The problems that you present to you 19 years ago are the same. Maybe just change the address, but you have the same problems. But I think you need to have young students, undergraduate students, residents, keeping working and try to improve the quality of health in our country. It's very difficult. And you need to dedicate and have a symposium like this one, who was a very important opportunity to discuss. We are here 5 hours discussing different specialties, general surgery, you had here emergency medicine, neurosurgery, orthopedics, anesthetists, discussing about some solutions maybe in the future. It will not be difficult. So, sorry, I speak a little bit in Portuguese, so you cannot understand. Em português agora, agradeço muito à Academia Nacional de Medicina essa oportunidade. Eu acho que nós temos uma missão a desenvolver, né? A experiência que o professor Frederico Arnaud demonstrou aqui, ele até pediu desculpas por causa do horário do voo dele aqui em Santos Dumont, ele teve que correr para lá, senão perderia o voo. Mostra que é possível, sim, nós fazermos algo melhor nesse país. Medicina de emergência foi criada em 2015, 10 anos atrás, com um programa de 10 instituições, com um programa conjunto de residência médica em 3 anos, acesso direto. E eles ocuparam essas vagas. Os primeiros anos não foram fáceis, eram 2 candidatos por vaga, mas hoje tem serviço que chega a ter 20 candidatos por vaga. A medicina de emergência não era uma especialidade. Depois que o professor Irineu Velasco, da Universidade de São Paulo, vestiu essa camisa e defendeu essa causa, em menos de um ano, o Torpedo Portari, a medicina de emergência passou a ser especialidade. Você saber a força que uma universidade tradicional como a USP pode ter no cenário nacional. Mas o Brasil não é a Universidade de São Paulo. O Brasil é o Brasil. As diversidades que nós temos nos diferentes cantos desse país Dentro da própria cidade do Rio de Janeiro, você tem hospitais com qualidades, dificuldades totalmente diferentes. O trabalho é muito difícil. Atrair jovens para a cirurgia geral hoje já é uma missão complicada. 60 horas semanais, né, para poder trabalhar, estilo de vida, o número de aplicantes para a cirurgia geral, pelo menos na minha universidade, a gente estuda isso, vem caindo lentamente nos últimos anos. Novas áreas surgiram, novas especialidades surgiram que se tornam, às vezes, mais interessantes, do ponto de vista de mercado de trabalho, resultados a curto prazo. É uma geração que quer, muito rapidamente, crescer na sua carreira, seja no mundo público ou privado. A medicina de emergência tem hoje 80 programas de residência médica, estão formando quase 1.000 médicos emergencistas por ano. Talvez daqui 10 ou 20 anos, nós tenhamos, nas emergências do país, apenas médicos qualificados, e não esses recém-formados que estão vindo uma formação cada vez pior, piorando aos nossos olhos. Quem é professor das faculdades aqui percebe isso. Até escrever português está ficando uma coisa difícil para uma nova geração, até ortografia. Então, o trabalho é muito grande. Espero que, antes de completar 200 anos da Academia Nacional de Medicina, nós tenhamos consolidado essa nova especialidade no Brasil, que já existiu, que chama-se Cirurgia do Trauma e agora Emergência Cirúrgica, em parceria com o Colégio Brasileiro de Cirurgiões, em parceria com a Abramed, que quem convive com o cirurgião do trauma no dia a dia não é o cirurgião geral, é o médico emergencista, em parceria com a ortopedia, em parceria com a neurocirurgia, e todas as outras especialidades que acabam fazendo parte de um grande departamento de emergência. Não é uma missão fácil, não vamos mudar isso de um ano para outro, vai ser uma geração. Mas se nós não começarmos agora, quando eu vir ao Rio de Janeiro, depois de me aposentar, daqui a um ano, se eu tiver um sinistro de trânsito, talvez eu fique preocupado para onde eu vou ser direcionado, que às vezes a gente pode escolher, que o pré-hospitalar leva, e quem que vai tratar de nós. Nós estamos tendo o momento e o tempo para fazer isso. Então, agradeço muito a professora ELIETE Bouskelar, presidente da Academia Nacional de Medicina, esse ambiente que deixou todos os nossos convidados internacionais impressionados. A quantidade de fotografias que eu vi eles tirando aqui vai circular o mundo. Nós temos aqui colegas de 9 países que vão levar essa mensagem da academia, e fico muito honrado de ter tido esse espaço, professor Rossano Fiorelli, que proporcionou, e amanhã nós encerraremos o World Congress of Trauma and Emergency Leagues, um evento de neurotrauma com o Dr. Andres Rubiano, lá na Sociedade Brasileira de Anestesia. Amanhã será o 15º consecutivo de educação em cirurgia do trauma. Se mais professores fizerem isso, Brasil afora, quem sabe esse país melhore ao menos um pouquinho. Vocês não precisam entender, porque not understand what I talk about. Thank you.
I would like just to remind everybody that in 4 years, the National Academy of Medicine will be 200 years. That's the oldest scientific and cultural entity which still functions in Brazil. So we are very proud about it. And I would like to just kind of give some kind of saying from what Professor Fraga just said. Brazil is definitely not for beginners. It's a problem. Okay? Thank you very much and good night.